Hi, my name is Jeffrey Schwartz. I'm a senior recreation therapist at Incarnation Children's Center. I've been here for 13 and a half years.
Hello everyone, my name is Professor Jasmine Edwards and I am the Director of Therapeutic Recreation and Volunteer Services here at Incarnation Children's Center. In addition, I'm also adjunct faculty at LaGuardia Community College's Therapeutic Recreation Program. So welcome to our session, which is entitled The Use of Behavior Modification with Children, Adolescents, and Young Adults.
So the objectives that you're going to learn through this are to obtain foundational knowledge regarding the practice of behavioral psychology, to be exposed to an overview of the API process in the development and use of a behavior modification program by a therapeutic recreation professional, to identify basic principles needed to develop a behavior modification program in any setting that works with children, adolescents, or young adults. And upon completion of this session, participants will be able to verbalize the history and theory behind the utilization of behavioral modification systems and programs. They will also be able to identify and describe examples of positive and negative reinforcers. They'll be able to identify and describe examples of positive and negative punishment. And they will be able to describe and demonstrate knowledge to create a behavior modification program for their facility.
Other topics that we will go over are the introduction about Incarnation Children's Center, the facility itself, and an overview of the STEP and incentive program that we are currently using at Incarnation Children's Center with our residents. So let's talk a little bit about the history of behavior modification in practice. So in our research, we learned more about Edward Thorndike, and in 1898 his philosophy and what he was known for was for the field of psychology for his work in learning theory. So the law of effect was the principle that he developed, and it suggested that responses that produce a satisfying effect in a particular situation become more likely to occur again in that situation, and responses that produce a discomforting effect become less likely to occur again in that situation. So Thorndike's principle, what he was really trying to explain was that the development of operant conditioning within behaviorism. So to break that down a little bit further, operant conditioning, sometimes also referred to as instrumental conditioning, is a method of learning that occurs through the rewards and punishment behavior modification system. So through operant conditioning, an association is made between a behavior and the outcome for that behavior. Now these outcomes can be either positive or negative depending on the elicited response. And these outcomes can either be interpreted as a reward or a reinforcer or as a punishment, depending on the elicited response. So more on the history of this practice. When we talk about behaviorism, what is behaviorism? What is the definition? Behaviorism is defined as a psychological approach which emphasizes scientific and objective methods of investigation. Behaviorism is primarily concerned with observable behavior, as opposed to non-observable internal events such as thinking, feeling, and emotion. It's something that you can see, something that is tangible. That is more behaviorism as opposed to something that is intangible. This approach, which was first introduced in 1913, is only concerned with observable stimulus response behaviors and claims that all behaviors are learned through interactions with the environment, quoted by Watson. The theoretical goal of behavioralism is to predict and control behaviors. So following in Thorndike's study about his psychological practice regarding behaviorism and operant conditioning, B.F. Skinner, he came along and he was fascinated with the study of Thorndike. and he wanted to study the consequences and human behavior. Skinner's study of external causes and consequences of human behavior resulted in his revised theory, which he refers to as operant conditioning learning. So Skinner's theory of operant conditioning learning was built on the ideas of Edward Thorndike. As stated previously, through operant conditioning, an association is made between a behavior and an outcome for that behavior. These outcomes can either be positive or negative, and they can be perceived as a reward/reinforcer or as punishment. Think of when you're as a child, when you touch the cookie jar and your parents tell you don't touch the cookie jar until after dinner, and later on when you eat your dinner and you eat all your vegetables and you get that cookie, that's your reward, your positive reinforcer. So you would the child associates listening to their parents and later on eating their vegetables and they get their cookie.
Or on the other hand, you go ahead again and you reach for the cookie the second time, and then your parents tell you that you're not getting a cookie because you didn't listen to what they were saying, and that would be as a punishment.
So when we're talking about reinforcement is defined as the operation of administering a reinforcer by the experimenter. It's the most fundamental first step to operant conditioning learning. Reinforcers act as stimuli to increase the rate or probability of the responses that follow. Reinforcement can be perceived either positively or negatively, both of which increase the frequency of an operant. So remember Skinner's definition? Skinner used the term operant as a reference to any active behavior that operates upon the environment to generate consequences. So let's give an example. Food. Food and approval are two types of positive reinforcers. Now, while pain, anxiety, and disapproval are among a few examples of negative reinforcers. The reinforcers that affect the rate of the operant can be either primary reinforcers or secondary reinforcers, and it's important to distinguish between the two. Primary reinforcers are directly related to an organism's survival. For example, we're talking food, water, warmth, pain, etc. Secondary reinforcers include characteristics that are acquired with experience from the environment, such as receiving praise, getting good grades, earning money for a job well done. Those are some examples of secondary reinforcers. Now let's talk about punishment. Punishment, although a derogatory term to use, negative reinforcer would be more of an optimal term to use, but punishment is defined as the opposition of reinforcement. The use of punishment can be very controversial in today's society because it just has such a negative connotation to it. So for example, some cultures may value punishment as a strong characteristic, building, while others may not. And yet some cultures may follow harsher methods of punishment as opposed to other cultures. From a generational perspective, it could be debated that punishment may be viewed as negative and restrictive from the younger generation today, who may feel that the point of view regarding punishment is too restrictive. So older generations may view punishment as a necessity for strong character building, and that could be debated in today's more modern and more liberal point of view. Punishment refers to the phenomenon wherein a stimulus is presented to the organism after a certain behavior has been responded. Punishment decreases the rate of the same behavior being repeated again. As a child, we learn if you do something wrong and you do not listen, there is a consequence. You are given a punishment. It could be having to have a timeout because you did not follow directions in school, and during recess you have to sit out for 5 or 10 minutes while you watch the other children play. The punishment, the consequence for that young child is they have to sit still quietly while their other friends are playing on the playground.
And none of us liked those consequences when we were children, but you remember them, and it probably helped shape the way that you behaved in the future so that you didn't get the same punishment or something of that stage again.
Punishment can be presented either positively or negatively, and it really is a debate on what you would feel is more effective, both of which decreases the frequency of an operant. So going back to Skinner, he used the term operant as a reference to to refer to any active behavior that operates upon the environment to generate consequences. So again, negative stimulus will decrease the behavior. If you don't enjoy the consequence, you will not repeat the behavior. Positive punishment can be understood as the addition of something, which causes the decrease in the rate of the same behavior being repeated. So consider the example of a child being spanked for bullying. It's a negative connotation to bully. So if a child who is the bullier and he or she is spanked for that kind of behavior, then they will learn to maybe treat others more respectfully and not to bully other children their age because they don't want to receive any consequences from the adults in their life. Now, negative punishment, on the other hand, is the removal of certain favorable things from the organism's life, which then causes a decrease in the frequency of an operant. So consider an example of a parent reducing the allowance of a teenager for failing an exam or a class in school. That teenager, in order to have their allowance reinstated or even increased, they're going to want to try to aim for the straight A's in order to advocate to their parents that they deserve to have more money for their weekly allowance. Self-reflection on punishment. In your own life, what do you remember going through as a childhood? From both examples that were stated on the previous slide, reflect on the behavioral outcomes that would be generated. Consider the example of the child being spanked for bullying. Would the child associate bullying as something that gets him or her into trouble? What are your opinions? Do you agree? Do you not agree? Why or why not? Also, consider the example of a parent reducing the allowance of a teenager for failing in school. Would the teen study and work harder to improve his or her grades? Do you believe that would happen? Why or why not?
So this is a chart that shows the positive and negative stimuli that are either added or removed, and whether they increase or maintain the behavior, or whether they decrease the behavior. So if you're looking at the positive reinforcement, you add a pleasant stimulus to hopefully increase or maintain a behavior. Or for the punishment, you would add an aversive stimulus to decrease the behavior, such as the spanking for the bully. As a negative, you're going to remove the stimulus. So for reinforcement, you would remove an aversive stimulus to increase or maintain a behavior. For a punishment, you would remove the pleasant stimulus to decrease the behavior. So you can see the opposites to both the positive and the negative based on the outcome that you're looking to achieve.
So let's talk about Incarnation Children's Center. We have on this slide our mission and our basic statement, but we are a 21-bed skilled nursing facility in Washington Heights, New York City, New York. And all of our residents are either HIV positive or diagnosed with AIDS. We take children from birth to 21 years of age for admission. So we have a range of babies and young adults, and it has been a challenge to work with such a large age range, and we have found that behavior modification system that is person-centered has been really effective with our residents.
And we have to use a variety of those that we just showed you, based on the ages, based on the behaviors. It's something, there's no set rules. It's something that you work with each individual child, or teen or adolescent, to try and figure out what the best strategy is to get the behavior that you're looking to achieve.
So we are a licensed skilled nursing facility, and we are operated under the auspices of the New York State Department of Health, CMS regulations, and just like many of the facilities where I'm sure some of you work, we do have guidelines to follow, and we try our best to operate under those guidelines, at the same time providing person-centered care that benefits our residents. Everything that we do with our behavior modification system, we must fully disclose, is a trial and error. Some things have been successful and some have not, and we have utilized many behavior modification resources, and consulted with our psychologists and psychiatrists in how best to work with the residents.
And we have residents that come from all 5 boroughs. We have residents, again, varying in age, varying just in their backgrounds and who they are when they come to us, which adds to the challenge of what we have to go through, because they are very different, and what works for one and what you think might work for another one, the same age, similar in who they are, doesn't. And it's just because each person learns in a way that helps them, that works for them. So it is a lot of that trial and error, and when something doesn't work, you come and you meet again and you figure out, let's try something different. And it's, you don't give up, you don't stop, you just keep looking and finding the new things, and then finally you do find something that works. We've gone through with a variety of different ones with individual residents here, until we finally have come to something that actually works for that resident. And then other residents will say, I want to do what they do, and we say, listen, everyone is different, and we can try it and see if that's going to work, or when we're talking about the positive reinforcement. But sometimes it doesn't work, and we have to come up with a different strategy. It's all about strategizing.
The mission of Incarnation Children's Center. ICC believes that in an ideal circumstances, every child should be healthy, live at home, and be surrounded by a loving family. However, for some HIV-positive children, this is not possible. Some children are chronically ill and have care needs that are too complex to be provided and cared for adequately in a home setting. For children who need the services of Incarnation Children's Center, ICC acknowledges that they are not a replacement for a child's home or family. But on that note, we do strive to make it as home-like as possible. Some of our residents come here for respite care because their families are going through a lot of stress or a lot of maybe changes in the household. We have residents who are placed here through ACS, under the direct auspices of ACS, due to usually it's medication adherence issues. The child, the teenager, the young adult may not be taking their medications at home, and it's affecting their physical health and their T-cell counts, and just being healthy overall. So because these residents are immunocompromised, it is very important that taking their medication be a strong focus of why they're living here. However, we have found a lot of the children, the youth here, they do not like taking their medications. They don't like the side effects. They don't like the taste of the medications. They don't like that they have to take so many pills. We have residents who come and they are taking 12 or more pills a day, and they are just tired of having to do so. And this is where using the behavior modification system has been really effective.
And also, we've had a lot of residents that have been here for many, many, many years, and we're helping them grow up, and we're teaching them the skills and the coping skills and all the things that they're going to need to be successful when they don't live here anymore. And again, these systems help make that happen. The residents sometimes don't like them, and that's part of what life is. We all have behavior modification systems through all of our lives. And we'll talk more about that when we get to them.
Here at Incarnation Children's Center, our care model is that we see a child's placement at ICC as a multifaceted treatment opportunity. So in general, a child is referred for medical treatment, yet there may also be educational, psychological, and social needs that must be addressed. Our team's approach is interdisciplinary. It's family-oriented and community-focused. Our team works not just with the child, but also with the family and the various clinics and agencies supporting the family as well as the resident.
It's truly a team project.
So now I want to go back to the behavior modification system, but not focusing on the history from Thorndike or from Skinner, talking about how we took those approaches and modernized it for a behavior modification treatment model here at Incarnation Children's Center, also we refer to it as ICC. So the behavior modification treatment model is based upon a premise of relearning acquired behavior. Behavior modification in itself is used to change behavior and reduce maladaptive behaviors by means of techniques that include negative and positive reinforcement, imposing environmental limitations, goal setting, and conditioning. So for example, we have had to use behavior modification to encourage our residents to take their medications by offering reward systems, and we have found that has been very helpful. And we will talk more about our reward systems as we move along. It's also important that every time we create, that you understand that every time you're creating a person-centered behavior modification system, there needs to be goals for that particular resident. The goal setting involves remaining committed to an established objective. Goal setting replaces undesirable behaviors. So for example, behaviors in conflict with the goal. So again, the activities and behaviors, we want it to reflect the goals and objectives of our program, as well as the goals and objectives that we have identified through the API process for our individual residents.
And remember, it says involves remaining committed. That word committed is an important word. It's not something that may work overnight. It may not. It may take a little while to do that reinforcement, to get them to understand what it is that you're looking for. And you have to be committed. You have to stay calm. You have to be the one that allows that to happen and work with them and explain to them why you're doing what you're doing. But that word committed is really important.
Behavior modification programs form the core of many, many residential treatment facility programs. Such programs have shown success in reducing recidivism and in adolescents with conduct disorder problems, as well as with adult offenders. Other forms of giving positive reinforcement in behavior modification is in providing compliments, approval, praise, encouragement, affirmation, and of course monetary incentives. Now that has been our most successful, the monetary incentives, but you do not have to use cash as the only form of positive reinforcement. But it is very effective. Behavior modification is used to treat a variety of problems in adults, adolescents, and children, and research has shown that it also has been quite effective in doing so. A variety of information can be found on the use of behavior modification to successfully treat obsessive compulsive disorder, attention deficit ADHD, attention deficit hyperactivity disorder, various phobias, anxiety disorder, separation anxiety disorder, oppositional defiant disorder, as well as many other antisocial and behavioral health and mental health disorders, all of which are common diagnoses among children, teens, young adults living with HIV and AIDS in treatment facilities and in residential facilities.
So we have dealt with all of these disorders and more And again, the challenge is when you have 21 residents of various ages with various diagnoses, it becomes a challenge to you have to tailor each person's behavioral modification system towards the goals that you have set forth with that individual.
So, at Incarnation Children's Center, how did we implement our behavior modification systems? And I say systems with an S because we have had many, and we are constantly, as part of the API process, evaluating our behavior modification programs and making adjustments as needed, and working with the team and really just getting feedback from the team as well as the residents. If it's effective, what they are looking for, what was not effective, what is not working for them, the who, what, where, when, and why. So I will tell you for who, the target population in this case are children, teens, and young adults diagnosed with HIV and AIDS with a history of behavioral disorder. Residents range in the age from newborn to 24 years of age. Now I know we said that we're admit residents up to 21. However, that's our admission criteria. Residents can stay at Incarnation Children's Center up until their 24th year of age. What? There was an increase in negative behaviors such as fist fighting, poor medication adherence, and missing curfew. So regarding missing curfew, a lot of our residents are allowed to go out for school, and then we give them a curfew to come back. They are able to commute back and forth from the center to school. Or for those who have family involvement, they were going to visit their families, and then again they had a curfew to return by a certain time, and that became problematic sometimes, curfew. Medication adherence, most of the residents are here because of medication adherence issues. And when you're immunosuppressed, I mean, taking your medication, I can't stress how strongly it is very important that the residents take their medications as ordered in order to sustain good health. The behavior issues, teenagers in particular, it was more challenging with the teenagers and young adults, and it is more challenging, continues to be. The fist fights, the verbal arguments, it's teenagers are, it's a challenge. And for any of you who have a teenager in your life, then you can understand our dilemma.
And then think about having up to 21 of them co-ed living together on the same floor in the same building that are always around each other, and especially recently 24 hours a day. So think about those challenges that arise from that.
Where are we located? We are a 21-bed skilled nursing facility located in New York City, Washington Heights to be more specific. We are open 24 hours a day, 7 days a week, 365 days of the year, 366 days during the leap year. And during the pandemic, it has felt longer being on lockdown. Why do we have to implement a behavior modification system? Well, a lot of the residents were missing meds, and this resulted in increased viral loads and decreased T-cell counts, which for someone diagnosed with HIV and AIDS, that is equals not good for your health. So missing curfew was also a problem because they have to maintain census, and that affected billing. And anything that affects billing affects administration, because billing is how the center is able to stay afloat and stay open. The physical fights resulted in police having to be called to the center several times a day. And I have to say, as my colleague can agree, I think the police officers were getting tired of being called to the center several times a day for the fist fights and for the physical aggression that was happening on site. And they were beginning to know us by name, and we're like, again? So,
And, just when you think you have it figured out, you might get a new resident that comes in, and then that new resident may trigger things in the other residents that maybe make them more anxious, or some other, something else comes out, and boom, now we have to start all over again, not only with the new resident to try and decrease the behaviors that they are using that are triggering the other residents, but also to try and help the other residents increase the behaviors that are able to help them cope with the frustrations or the anger or the anxiety that they're feeling. So it's a constant ebb and flow. Just when you think, hey, yay, things are calm, yay, we can relax, something happens, someone comes in. It's a never-ending process. Goes back to that word committed that we talked about before.
I will say the pandemic has really changed things. The way we operated before the pandemic, there was a little more leeway for residents to have more personal space because they were going out to school, and that gave them time away from the facility. Being on lockdown and doing distance learning, they are in the building all the time. Their medical appointments were pretty much canceled for the first several months of the pandemic. So even going to a clinic appointment, most of them see their doctors off-site to be followed by HIV and AIDS specialists. So they would enjoy that time away from the facility. And now that wasn't happening. The visits with those doctors became virtual. So they were in the building with all the same staff, all the same residents, just day in and day out. It has been even more challenging during the pandemic, and I'm sure a lot of you might be shaking your head saying, yep, I know exactly what that was like. They are stir crazy.
And recreation groups had to change because we couldn't all be in the same room together because we had the social distance. As I'm sure you all know, it just was a huge challenge, and it still is a huge challenge.
So overall, our behavior modification system, we use money. Teenagers, young kids, they respond to money. And the reason that we use money is honestly because they were using the money to go out into the community, and we have a lot of like little 99-cent stores, dollar stores where they could just go and buy little gifts for themselves or little trinkets to put in their room to make their rooms more personalized. And we were fortunate enough that we had the budget that we could do this. And as think of when you were young, I remember I had an allowance. I did my chores and I got an allowance. And I don't know, not everyone was fortunate enough to maybe have that growing up in their childhood. But I think a lot of youth learn about the value of money and earning money from their childhood experiences of doing things at home to earn an allowance. So this is why we followed really that same principle. So we have monthly rewards, we have a monthly incentive, and we have weekly incentives. We offered Metro cards, we had a token reward program, and I'm gonna let Jeff get actually more specific about those programs that we do individually for our residents.
Yes, we also had daily programs for some of the residents that needed more reminders as opposed to knowing once a week how you did. A daily thing where we would go over with them daily how they did. Just on at least the last one with the token reward system, we had a young one. He was about 10 years old, was having some difficulties, and so we implemented a ticket system where he would earn tickets for good behavior, and the ticket said, hey, yay, I got caught behaving good today. And so things like cleaning up after himself, or saying thank you, or saying please, or helping with something. If someone caught him doing something good, and caught is in quotes, we would give him 1 or 2 tickets. He had a list of, if I get this many tickets, I get this reward. If I get this many tickets, I get this reward. So he was able to decide whether he wanted to save them up, how he wanted to spend his tickets. And it worked very well. And for the beginning, we were just giving tickets. And then as he got very used to that system, we added in a little bit of where we took away a ticket if he did a negative, something negative. So we took away, that was the punishment. And it was a shock to the system at first, but eventually it caught on, and he realized, like, okay, so when I do the good things, I'm getting tickets. When I do the not so good things, I'm losing tickets. And that system slowly worked for him. And by the time he went home to his family, it worked really well for him by the time he left.
With that young man and the ticket system, there were not everything involved money. There was you unfortunately cannot see Jeff's desk right now, but he has all these wonderful knickknacks and toys and activities on his desk. He has this gigantic slinky, and one of the things that this young 10-year-old said is, if I earn a certain amount of tickets, I can sit at Jeff's desk and pretend to be Jeff. And he admires Jeff very much, and just having that opportunity to sit and pretend to be Jeff Schwartz for an hour was really important to him. And that is something that did not cost us any money. He enjoyed doing it, and even pretending to answer the phones and pretending to type emails and being very busy and doing paperwork and writing in charts, just pretending to do all these things made him so happy. And again, he saved up his ticket so that he could have the opportunity to do so.
And using my mannerisms or making, the comments that I make, it was just fun for him to do a role play kind of thing. So this is one of the systems. Oh, well, this is actually a description of the system and the rewards that we've given. So we have a system, and there's step 1 through step 5. So for being on step 1 was essentially like you were getting punished. And so this is a weekly one. So at the end of the week, I would take the forms that the CNAs would fill out, or staff would fill out, whether they did something positive or whether they did something negative. They would earn points based on the positives and the negatives, and I would add them up at the end of the week, and then I would determine what step they were on based on those points that I determined figuring out. So if they were on step 1, basically they were punished, and that was if they basically had 30 points or less. And it's kind of hard to get 30 points or less, or easy depending on the behavior that you're choosing to do. If you were on level 1, you were not allowed to go on the trips, the off-site trips. You didn't get an allowance, and you didn't get a Metro card. This was it was a punishment, and it worked. They were not happy, and it helped them strive to at least get on step 2 thereafter. So for step 2, which was anywhere between 31 and 64 credits or points, they would get a Metro card, and this was for the ones that were able to travel independently. They would get a Metro card, and this was also before COVID. And they were able to participate in all off-site activities. And they were eligible for day passes if they were age appropriate, and therapeutic leave as well if they were age appropriate. Step 3, we had those same things as step 2, and then we added a $15 allowance. That was anything over 65. We kind of described it as, think of it as taking a test in school. When you got a 65, you passed. So if they were on step 3 for a certain number of weeks, that would be 3 consecutive weeks. On that 4th week, they would jump up to step 4. That would give them $20. If they were on step 4 for 8 consecutive weeks, then they would go up to step 5. That was $25 allowance and two Metro cards. It became very important for at least a lot of the residents to try and get up to that step 5. It was a really big deal, and those kind of things were what shaped their behaviors. So if you look at the bottom, the examples of credit for things that they lost credits for were leaving a group room without permission because we just need to know where they are in the building. Again, co-ed, teenage, you can understand. Also going in a peer's room without staff permission, similar things. The 3rd floor is where administration is, and sometimes you're talking about residents or you're talking about business, and you obviously with HIPAA, residents should not be able to hear these things. So the residents needed permission to come up to the 3rd floor. So if they came up without permission, they would lose some credits. If they refused their vitals, we asked them once a week to take their vitals, their height, their weight, their blood pressures. If they refused that, they would lose some points. When they went on day passes, we asked them to come back at curfew. They would lose some points for coming back late. Similar to when I got back late from my time when I was a kid, I got in trouble. We try to keep the place clean, and so we ask them to keep the food and drinks off the second floor where they live. If we found that there, we would try and they would lose some points. Again, meds, very important, and with these meds, it's really important that you take them at a specific time. So if they came late for meds, they would lose some points. Again, to just reinforce, it's really important that you take these meds at a specific time every day. Consistency is what really beats this disease. And then the stairs, just using them without permission. Again, stairs are a danger. It's a safety issue, and if they slip and fall and no one knows about it, it's a big problem. So those are just some of the examples that they could lose some points or credits.
And I want to go over the terminology. I know that we go back and forth with positive reinforcer, negative reinforcer, reward, and punishment. When you're working with more of an adult population, I think that they will respond better to the negative reinforcer, positive reinforcer terminology. With the youth, we found that when we say, well, this is a negative reinforcer, this is a positive reinforcer, they looked at us confused. And then when we use, well, this is your consequence, your punishment, and this is your reward, and oh, okay, I know what you're talking about now. And that's why we were using the word punishment. It's just from a child point of view, they understood that terminology. The positive and negative reinforcer terminology was just a little sophisticated for some of our residents.
And also, just on the opposite, they were also gaining points for taking their medicine on time. They were gaining points for good behavior. They were gaining points. So again, it's showing that if you do the good behaviors, you're going to get the points. And if you do the negative behaviors, you're going to lose the points. And since you want to be on steps 3, 4, and 5, they're going to push to do those the positive behaviors more than the negative behaviors.
Regarding, if you're wondering, well, what behaviors did we decide to put on the sheet, we don't have that specifically listed because it was specific, this is part of the API process. We met with the team, and for each individual resident, what are the positive behaviors that we want for this resident? And if there were any negative behaviors that we wanted to decrease, what were those behaviors? So that's why we don't have specific examples, because it really was person-centered. So meet with your team, you're part of an interdisciplinary team, utilize your team to help create the behavior modification for each of your residents. So what were our goals for the behavior modification at Incarnation Children's Center? For all the residents to become undetectable of the HIV virus within their bloodstream. Undetectable equals untransmittable. And that was something that we highly, from all the departments, all the disciplines, that we wanted the residents to be at their healthiest. And that means being undetectable. So therefore, taking their medications to decrease their viral load and increase their T cell count. That was what was needed. And if they're not taking their medication, as Jeff said, as specific as was identified by the doctor as prescribed, that was the key. Also, we wanted to decrease the number of times the police were called to the facility due to the physical assault of one resident upon another. We wanted to stop the fighting, and so that was another one of our goals. Another goal was to motivate residents to return to the facility on time for curfew. Also, because those residents who missed curfew, oftentimes their med times were usually at curfew time. So if they missed curfew, they were missing their med time, which goes back to our first goal, undetectable means untransmittable. Another goal that we had was to give residents an opportunity to earn cash to spend on their personal interests for personal gain of monetary value. Objectives. Our objectives and for our behavior modification system here at Incarnation Children's Center was to increase the antiretroviral and mental health medication compliance to 100% for each resident. By rewarding residents with bonus points, as Jeff had mentioned, towards earning allowance and or receiving a financial stipend. Also, the objective was to praise, recognize, and publicly acknowledge residents for demonstrating appropriate behavior by using their coping skills instead of imposing verbal or physical aggression towards others. Bonus points can be given and are given to those residents who were able to use their coping skills as opposed to using their aggression. Really, we wanted to make sure that a lot of residents come here and they have not been praised. They have not been applauded for, they've been put down a lot. They have gone through a lot. They're not coming necessarily from homes that were supportive. So we find that giving praise really just went a long way. Of just saying, great job, you took your medication today. I know it wasn't easy for you because of how it makes your stomach feel, but you did it, and we're so proud of you. And this is your reward for doing so, and keep doing so. And we're here for you, and we're supporting you. And we found a lot of residents actually really appreciated the praise more than they appreciated getting the money.
And they would constantly strive to continue to make us proud, and loved when we would say, you're doing even better than you did last time, and you're taking the medicine so much easier, and I'm so impressed. And it became something that was really special for them to get that kind of positive reinforcement in that way.
So you might be wondering, did this really work? Did this really help? Well, although ICC does not have formal research data to present to you today, ICC does keep track of how long residents have been on step level. So we do have a tracking sheet that we can show you on the slide, and what it showed is that residents were striving to get to that level 5, and the only way to get to level 5 is to be on level 3, move up to step 4, move up to step 5, and they were striving for it. And when they got to step 5, we kept track of how many weeks they were on step 5. And they would say, I'm on step 5 again this week. How many weeks does that make? They even wanted to know these numbers. So that showed our success rate.
And we would throw parties for residents as they reached certain numbers of weeks on step 5. So they had things to look forward to. Even being that step 5 was the top step, there were still things within that step that they were looking forward to earning. So this is the tracking sheet that we would have, and you would see the different groups that we had, and we use initials, and these are not initials of residents that live here currently, or anyone that has lived here. So we would put their initials on the left side, and you can see the O and the Y next to their initials, which would stand for the older or the younger residents. Their steps would then be listed next. So steps 1, 2, 3, 4, or 5. Following that would be the number of weeks that they were on that step, and that was really important to them, like we just said. And then, depending on their age, they were able to have independent travel privileges throughout the facility. Again, just letting us know where they're going. Again, that was part of leaving the room with permission, not going into rooms without permission. That was still part of what they would have to do, especially for the ones that had those independent privileges. So we also did in COVID times, we did a monthly stipend reward, and this was something just to give them a little bit more to look forward to. But with the monthly stipend, we were a little more. We wanted a little more. We wanted a little more perfection out of the residents. So as you can see, like resident AA will earn a monthly stipend of $50 if all requirements listed have been met for the month. So that's taking all of their medications and treatments as ordered. So that's every day, on time. No spitting, biting, hitting, or scratching of any staff. If resident AA did any of these things within that month, they would not have earned their stipend. They could still earn their weekly level, and their weekly things would change based on their behaviors as well. But this was something special that we added on top, just because, again, to show that medication was extremely important for what we needed them for their health. Resident BB, we had more things. Again, all requirements have to be met, but they're probably a little bit older, and they're able to do more, and we think that they can handle more. So with them, again, it's take all their medications on time, and now you can see they have 2 times that they have to take their medicines, 7 a.m. and 7 p.m. They have to attend all medical appointments off-site and at ICC and comply with the treatment plans that their doctors have ordered. They would have to comply with the face mask when isolation is ordered. They would have to shower daily, brush their teeth twice a day, no destruction of property, not entering the staff-only areas, the staircase, the nurse's station, the kitchen, the basement, no riding the elevator without staff, and cooperating with the bedtime routine. Again, all of these things had to be done in order for them to get that $50 stipend.
So I want to point out that resident AA, as Jeff said, had less things than resident BB, because remember your API process, everything is person-centered. Resident AA, although she is a 21-year-old resident, she is severely developmentally delayed. So her system, we narrowed it down to the main things and main behaviors that we were trying to change and made it very simple. Resident BB, this was based on a 19-year-old resident with full cognitive capacity who basically it's behavior issues and medication adherent issues, but is very cognitively at his level and was able to follow directions very easily. So that's why there's more on his list. API process all the way of assess your clients, know what their needs are, what their capabilities are, and then this is how you base your behavior modification for that resident.
This resident was a little bit older because we increased the money to $75, and you can see that we also increased the number of things that we're asking them to do to earn that $75. Again, take the medications and treatments, including their oral hygiene, attend the medical appointments. Now we've added return from passes before midnight, not exceeding their therapeutic leave allowance. So this resident will be over 21. They were allowed to have one overnight every 6 weeks. They would not allow to have more than that. Not interrupting the nursing report, which is daily at a certain time. Complying with the face mask, no food on the second floor, no code 10s, elopements, running away, no incidents caused by their behavior. A code 10 would be something that would require all available staff to help with an emergency situation. No contraband, no destruction of property, no spending time in other residents' rooms or allowing them in your room without permission. Do not enter staff-only areas, and no provoking residents to tease each other. So you can see we added, there was a little more money, but there was also more things that we needed them to comply with.
Resident DD. So as you see, these are just more examples that we have, and these are actual residents. The names, obviously the initials we have changed, but these are residents that are residing at ICC, and these are the components of their individualized behavioral modification system. And it has been effective. Now there are some days where it is not effective and we do have issues, and you can't let those days determine that the system isn't working. Some days things just don't work out and you try again tomorrow, or if we meet as a team after a week, we see behaviors that are just problematic, then we regroup as a team, because we in addition to our daily meetings, we have weekly care planning. So during care planning, that's when we'll discuss maybe we need to adjust a resident's individualized behavior modification plan. So going back to our success rate, according to ICC's medical director, over 90% of our population is undetectable. We are striving for 100%, but I have to say 90% we are very pleased, and we will continue to strive for 100%. Meaning that their viral levels are drawn quarterly for data tracking by ICC's medical director. So that we do have statistics on. So they have to have their blood drawn quarterly so that she can look at their viral load and their T cell count, and taking the medications successfully, regularly, we do see the results, and she is very pleased with the results for the facility overall. And she really attributes the behavior modification system to the success rate of the residents maintaining medication adherence. And she is very involved in the behavior modification system and the implementation of the system. So many of our residents are admitted with a 10 10 to 12 pill daily medication regime. When they are successfully discharged, it is because they have been weaned down to 1 pill a day regime. So, and still maintaining their undetectable status. So that is always our goal, and when residents are being discharged, that is a huge success rate for our facility.
So the frequency of incidences resulting in staff having to call 911 for police assistance has decreased significantly as well. Our administrator does track those, and he also says that the behavioral modification system that we have is what, in his opinion, is helping to lower the incidences of us having to call 911 for police assistance.
Every time we call 911, it is documented for the tracking for the New York State Department of Health, so that is how our administrator is tracking that data. So things to keep in mind. I hope this is not a surprise to any of you. The API process. Assess the client. Yes, we have overall goals as a facility, which is the medication adherence for everyone who is here. But again, the behavior modification system, as you saw for resident AA, BB, CD, and DD, are very different. Why? Because they are different personalities, they are different ages, they have different developmental age ranges. You know, they may be biologically an age, and developmentally their age is completely different. So again, their cognitive abilities, their physical abilities. So the assessment process is key. Planning. Behavior modification, we are doing it as a team, and we meet during our weekly team meeting to discuss, does anybody's behavior modification system need to be changed? Is it working? Is it effective? Are we seeing results? If it's not working and we're seeing negative results, then what do we need to do to change the outcome? Implementation, right? When we come up with the plan, we actually then have to implement it. And implementation is not the end. You need to evaluate, reevaluate, and reevaluate, because the residents change. Especially, as Jeff mentioned, there are residents who have been here for several years. So as they're getting older, their behavior is changing, their needs are changing, their interests are changing. So we need to understand that and change with them and change their behavior modification plan.
And as one goal is achieved, maybe you work on another goal that you were hoping to be able to get to. So it's just as times change, you change with them.
So things to keep in mind as we come to a close with our presentation. Every behavioral plan should be individualized and person-centered. Conduct an assessment of the targeted individual. Meet with the individual to develop his or her behavioral plan, and then draft a plan. Review the first draft with the team. Identify and review the targeted behaviors to be addressed. Now for your second draft, finalize as needed with the multidisciplinary team. Include any updates from family members or even teachers. We have consulted with teachers to change behaviors also in their schools when they were, even with distance learning, we're still communicating with the teachers. Ask for feedback from families and from the teachers as well, and take that into consideration. Repeat this step as many times as needed if you feel that the plan needs to be remodified. And lastly, review the final behavior plan with the targeted individual. Have a plan for how to monitor your positive and negative behavioral changes. Have a plan for how to implement the negative and or positive reinforcers or punishment. And have a plan to continually, and I stress continually, evaluate the individual as well as evaluate his or her individualized behavior plan. Now, is your facility a program, or is your facility or program in agreement with the use of behavior modification system or behavior modification program? You definitely want to find that out before you implement a program if it's not something that your administrator is in agreement with, or your medical director, or your CFO, whoever you may report to. Review any concerns with your supervisor, administrator, or your executive director. Review any concerns or restrictions with the team. Remain open-minded about the objective. Take a lead in facilitating this process. Maintain a positive and encouraging attitude throughout the process. Support, guide, and offer feedback to the targeted individual throughout this process.
So we want to thank you for attending our session. We hope it was informative. It's something that we strongly believe in, and we have seen it work. So it's something that if you're with your populations, it may be something that you use. It may be something that you're thinking of using, or maybe this is something new and you're like, oh, maybe this will work. Feel free to email either Professor Edwards or myself. We can answer any questions that you have and help you with whatever your needs are.
Thank you so much for listening to our presentation today, and we really hope that you got something out of it.